Good morning, ladies and gentlemen. My name is Dr. Michel Mawad, and I would like to spend the next 15 minutes or so discussing with you the management of acute ischemic stroke, the challenges and the logistics associated with it, particularly as it relates to Lebanon and to the Lebanese population. Acute stroke, by definition, is a sudden brain damage and lack of blood flow to the brain caused by a clot or a rupture of a blood vessel. So they are divided into hemorrhagic stroke, which is the minority. About 20% of people presenting with stroke is related to a hemorrhage in the brain, either hypertensive or a ruptured aneurysm. And the majority of them, about 80% of patients presenting with stroke, are actually ischemic stroke, where is a clot, whereby a clot has occluded an intracranial vessel. The hemorrhagic stroke is usually related to intracerebral hemorrhage, usually hypertensive, or to subarachnoid hemorrhage from a ruptured intracranial aneurysm or a ruptured intracranial arteriovenous malformation. Ischemic stroke, on the other hand, which is the majority of cases, is related to occlusion of the blood vessel, such as occlusion of the carotid artery from atherosclerotic disease, or dissection of the internal carotid artery. In essence, a large artery in the neck that gets occluded, carotid or vertebral. Or occlusion of an intracranial artery by a clot dislodging from the neck or from the heart and going north and getting stuck into one blood vessel, and that gives you an acute ischemic stroke, which is the vast majority of the cases. And finally, another category of ischemic stroke is the lacunar stroke, usually small, not visible on a CT scan, not resulting in a major clinical damage, and best seen on an MRI than on a CT scan, typically in patients who are hypertensive and diabetic. The epidemiology of stroke in the Middle East and in Lebanon, it's the third leading cause of death everywhere, including Lebanon and the Middle East, North America, Europe, and whatever. And to the very high cost to society, and remember, only 2 to 6% of eligible stroke patients receive RTPA or any kind of treatment. And therefore, حملة توعية مهم كتير بجميع البلدان وخصوصا عندنا بلبنان. We need to make sure people are aware that stroke is treatable and فالج منعالج مش فالج لا تعالج. So, and it's also stroke, if it's not treated, is actually and unfortunately the leading cause of long-term disability. What is the incidence of stroke and what is the burden of stroke in the Middle East and in Lebanon? In the Middle East and Lebanon, the incidence of stroke is around 2 to 300 per 100,000 inhabitants and is increasing year after year. Therefore, it has become imperative to heighten awareness of stroke both in the general population as well as in the healthcare community. So in the Middle East and Lebanon, stroke will increasingly become a burden in the coming years due mostly to the younger age of its population, and because they're all growing older. There is a significant need to increase public awareness of stroke and its risk factors to help people understand its negative impact on the quality of life, and potentially, if we can, as much as we can, to prevent this disease and its horrible after effect in terms of the disability. Coming back to the prevalence of stroke, the prevalence rate for stroke ranges between 500 to 700 or 800 per cases of stroke per 100,000 population. Assuming an average prevalence, a rate of 2 to 3 per 1,000 population, and the Lebanese population of about 6 million, the incidence of stroke actually in Lebanon, if you calculate it with this prevalence and the number of the general population, should be around 15,000 cases per year, somewhere between 12 to 18,000 cases per year. And It is more prevalent in males than it is in female, except in the atrial fibrillation population. And the mean age of stroke is within the 6th and the 7th decade. That means between the age of 50 and 70. Now, if one looks at the stroke burden in Lebanon, this is the specific data of stroke burden in Lebanon by age category, especially the stroke incidence in the vulnerable category, as we mentioned, of the age group between 50 and 70. So on your left is the red ellipse or the red circle that shows the prevalence of stroke and the stroke risk per 100,000 population in Lebanon per decade of life. And obviously, as the population of Lebanon grows in size, so will the projections of the incidence of stroke in the country. As we get older, as the number of the population increases, the number of stroke is definitely going to increase. So basically, there is an impending stroke epidemic in the near future in Lebanon and in the Middle East. We're really looking at the tip of the iceberg. There is a large population coming to the age vulnerable for stroke, which we're going to have to be dealing with. So we better address this issue soon, and we better try to figure out a system of stroke treatment in the country. Stroke risk factors prevalence, usually it is worth noting that all risk factors of stroke are in fact very, very common in the Lebanese population. Notably, hypertension, diabetes, pre-diabetic state, dyslipidemia, hypercholesterolemia, high triglyceride, and also the heavy use of tobacco among the patient population, among the Lebanese population, specifically not only cigarettes but argili. Argili is very prevalent and is far worse than smoking cigarettes, in my opinion. Now, let's talk about the logistics of treatment of acute stroke. Basically, the main principle of treating acute ischemic stroke is the timely antegrade reperfusion of brain parenchyma that is ischemic. Timely antegrade reperfusion of the ischemic brain, preferably within the first 6 hours after the onset of symptoms. The reperfusion can be of two kinds. It can be pharmacological, using the intravenous infusion of recombinant TPA in the first 6 hours, or more recently and much more effective is the mechanical reperfusion using either stent retrievers or thromboaspiration. So what is the really the management of acute stroke by thrombectomy? The clot retrieval procedure uses a special device that functions as a stent but on a stick. It's a retrievable stent. It is introduced in the body through the groin and advanced intracranially all the way to the face of the clot. And as time goes by, there is expansion of the stent retriever inside the clot. As it expands, it enmeshes and gets stuck with the clot, and then we can simply retrieval outside the body, thus re-establishing antegrade flow in the circulation that was occluded. So this is actually clot retrieval by using a stent retriever and physically pulling it out through a large mouth catheter. On the other hand, the thromboaspiration also reestablishes antegrade flow by simply getting a large bore catheter also in front of the clot and simply aspirating the clot using a large bore catheter that is advanced all the way in contact of the face of the clot and applying negative pressure simply using a suction pump from the outside. So two kinds of mechanical thrombectomy, one with a stent retriever or aspiration, and sometimes we combine both of these techniques in tough cases where we cannot retrieve the clot easily. So let us look together at the timeline of the effective treatment of acute ischemic stroke by using an example of a fictitious case of Mrs. Katya. Mrs. Katya is a 65-year-old mother with hypertension and diabetes who was one day having lunch with her family at a restaurant. And at about noontime, at 12 o'clock, her children, who were having lunch with her, noticed that she could not hold food in her mouth. الأكل كان عم بينزل من تمها, and had a facial droop and slurred speech. She could not express herself. They noticed there was something wrong here. So we have up to 6 hours where we can use RTPA, 6 hours where we can use RTPA, because after 6 hours the RTPA is no longer effective. As you see from the graph here, the effect of RTPA fades away within 6 hours. So therefore, if you want to use RTPA, you have to use it in the first 6 hours. Preferably, the window and the sweet window is the first 2 to 3 hours. You can extend it to about 4.5 hours, and not more than 6 hours, because then the hemorrhagic complications become to set in. So RTPA, preferably in the first 6 hours. You can extend it to about 4.5 hours. This is intravenous infusion of TPA, and ultimately you could actually stretch it to about 6 hours. However, what is really effective, and things have been proven like this, is mechanical thrombectomy anytime after the onset of the symptoms. Mechanical thrombectomy can be used within a few minutes from a stroke, especially when the patient comes to the emergency room and gets quickly to a stroke center. We can use mechanical thrombectomy, either using stent retriever or a thromboaspiration. And actually, studies have shown that mechanical thrombectomy is effective and actually is associated with improvement of a clinical outcome up to 24 hours after the onset of symptoms. So you can use RTPA, intravenous RTPA, in the first few hours, as long as the RTPA does not, or the infusion of the TPA does not delay the more effective mechanical thrombectomy.